Okay, so our last presenter needs no introductions. Stefania Bruno is consultant neuropsychiatrist and medical director at Blackheath Brain Injury Rehabilitation. She trained at Queen Square and also has a PhD in advanced neuroimaging at UCL. She's also got a visiting teaching appointment at IOPPN, and her talk is on the use of Concerta in a pretty complicated case of NMO.
Yeah, so you've worked out I'm actually here as an imposter in that I'm not a trainee, but I'm presenting on behalf of our trainee, Dr. Hudson. So this is a challenging case we've had recently of a patient with neuromyelitic optica spectrum disorder. So this is a relapsing autoimmune disease, which was historically seen as a variant of multiple sclerosis. It's quite rare. The prevalence is 5 in 100,000 and tends to be much more prevalent in women. Actually, it was described initially in 1894 by a French neurologist called Devic. And this was an illness affecting essentially the spinal cord and the optic nerve, so clinically characterized by optic neuritis and transverse myelitis. So all this changed in 2004 because the antibody was identified, followed by the antigen protein, which is aquaporin 4. It is a water channel that is expressed in the membranes of astrocytes. So this widened the phenotype enormously and also introduced the concept of an NMO spectrum disorder. So while in traditional NMO the brain involvement is very uncommon, in NMO spectrum disorders it's actually present in up to 90% and can be with a variety of different localizations, but I just want to draw your attention to the periventricular, the encephalic lesions that involve thalamus, hypothalamus, and midbrain, and can be associated with a number of clinical syndromes that are relevant in this case. So this case is of a 32-year-old woman who was fit and well, working as a paralegal in New York. The onset was in 2017 when she developed cognitive problems and hypersomnolence. She was found to be hypothyroid, and this was treated, but she didn't improve, and she underwent very extensive investigations, in the end turning out to be positive for the aquaporin antibody. At that point, her MRI spine was normal, but she had some T2 hyperintensities in the brain, and she was treated with immunosuppressant treatment, so IVIG, plasma exchange, and rituximab. She didn't improve. In fact, she continued to deteriorate and went to brain biopsy to exclude a thalamic tumor. The pathology was consistent with NMO, and she had another set of autoimmune suppressant treatment. She continued to get worse, and in fact, with new symptoms. A few months later, she started to show increased appetite and weight gain, and unsurprisingly, she then became hyperglycemic, and she had to start treatment with metformin. She came back to the UK with her family, and she was, in February 19, she was admitted to St. Thomas's with quite unwell, with drowsiness, vomit, unsteadiness, and behavioral change. At this point, neurologically, she had ophthalmoplegia, and she was confused, and she had some scans which were consistent with an acute subacute episode of NMO. She continued to deteriorate also from a metabolic point of view, and she had to be started on insulin. She also had autonomic dysfunction with tachycardia and pyrexia, which were felt to be of central origin. This is her L scan from March 19. Some of the sections, essentially the scan was the imaging was reported as showing multiple lesions from the basal ganglia, subganglionic regions, hypothalamus, thalamus, midbrain, pons, and cerebellar peduncles. At this point, they went in with another 2 infusions of rituximab, and the drowsiness improved. But she emerged with a very severe behavioral syndrome with disinhibition, which including sexual disinhibition, but uncommonly compulsive food-seeking behavior. And this involved locking herself in the kitchen, stealing food from other patients, and physical aggression towards staff. We were trying to prevent her from doing this. She had to be placed on 2-to-1 observations. She was referred to neuropsychiatry. Trials of sertraline and carbamazepine were ineffective. And at this point, she was referred to us, to our neurobehavioral units. And on arrival, she was on 41 units of insulin, plus a novorapid PRN and anti-diabetic medication. Her weight was 113 kilos and BMI was 42. And she was still displaying extreme food-seeking behavior, for example, grabbing a sugar bowl and emptying the content directly into her mouth. So at this point, we were a bit at a loss in how to approach this pharmacologically. We identified some seriousness from children with craniopharyngioma with overlapping anatomical lesions and very similar behavioral syndrome. So these children were treated successfully with stimulants, and we decided to give it a go. We put her on Concerta up to 72 milligrams, as well as a behavioral management plan. And she improved very rapidly. The food-seeking behaviors are almost entirely extinguished, but more importantly, the metabolic picture improved so that we were able to reduce and stop insulin and the oral antidiabetics. Also, she improved cognitively, and she has been able to engage in the full rehabilitation program. So we suggest that Concerta may be quite effective in treating organic hyperphagia. And on my last slide, if you want to see more of these interesting cases, you can enroll in the MSc in Clinical Neuropsychiatry at the IUPPN, where, as well as having taught seminars from a number of experts, you also have the opportunity of clinical placements in several neuropsychiatric units, including ours. So that's it.